Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Okay, everybody. Hello. This is the first time I've gotten to write assistant professor by my name, so that was very exciting. Thank you all for that opportunity. I hope you've got to join me for the previous two in which we talked about mobility, and now we're going to talk about mentation. I have, as usual, no conflicts of interest. We're going to meet a fictionalized patient, but one that I think will bring to mind several patients that we've all seen at our clinics. So Louise is a 74-year-old woman. She lives at home. She's got excellently controlled HIV and diabetes. She comes to your office because her son is very worried that she's not been herself. She's been neglecting taking care of herself. She's napping more often during the day, doesn't seem to be sleeping through the night as well, and no longer really wants to leave the house, which is atypical for her. Your brief exam is normal, and you review her medications, which for the sake of this case is kept very simple. She's on Biktarvy, she's on a statin, metformin for her diabetes, and an over-the-counter multivitamin. And so when I see patients like this, and when you send me patients like this, my management and my next steps is pretty much the same for every single one, which I've highlighted here. The first thing I do is talk to patients about what medications they're taking. Lots and lots of patients these days are taking things, as you know, that they buy from TV ads or online and aren't reflected in our medication lists. And lots of those have neuro side effects. So I make sure to talk to patients about that. Obviously, I talk to them about what other substances they're using. And then my workup starts with pretty basic labs for everybody. I always do a depression screening when these cases are brought up, and we'll talk about why. In any case, we should be doing those once a year anyway. We'll talk a little bit in about dementia screening and how to pick a test and what kinds of tests give you what information. And then we used to hold off on getting imaging at the beginning for pretty straightforward cases, but more and more guidelines are leaning towards getting at least one MRI brain with and without contrast, especially in the population with HIV. Okay, so for Louise, these are the lab results we get back. We see that her CBC is normal, her BMP has nothing really out of the ordinary. Her HIV remains excellently controlled. She's tested negative for syphilis. Her TSH is in a normal range. I want to pause there and say that if she had been on thyroid supplementation hormone or levothyroxine, that we want to aim for a TSH goal between like 3 and 5, which is different than the general adult population. And that's because a more or relatively hyperthyroid state is associated with increased risk of bone turnover and atrial fibrillation, two conditions we would like to avoid in this population. So we are a bit more conservative with thyroid supplementation. In this case, this was a routine screen and her labs came back normal. Her B12 is 190 and her lipids are at 70. EPIC does not flag B12s in this range, but I would like you to recall that in older adults, we have a higher B12 goal, greater than 300, and that's because study after study is showing that B12 is really, really important for nerve and brain function. So I wish EPIC or whatever EMR you're using would flag this as abnormal, but it doesn't. So in this patient, I would recommend either oral supplementation with 1,000 micrograms daily forever, or an IM injection of the same dose weekly, and then every other month, or switch over to daily PO. If you search this on UpToDate, studies will show that there's no difference between efficacy of oral and IM injection for B12 supplementation in older adults who are B12 deficient. The way I make this decision is patient preference, obviously. Lots of these patients, not Louise, but most of our patients have a lot of medications. And so if they're unwilling or reluctant to add one more pill, then that's an excellent patient in which I would add the injection instead. A lot of our patients are coming in often anyway. And then I don't have a good mechanism to explain this other than like general gastric atrophy, but it becomes more difficult to absorb B12 as we get older. And so I would recheck in 4 to 6 months after PL supplementation to make sure that your patient is absorbing it. This patient is also on metformin, which we know it further decreases the ability to absorb B12. And so if you're worried about B12 absorption, that's another case in which I would opt for the injection instead. We talked about how we should be screening our patients for depression at least annually. The likelihood of depression in older adults goes up when massive losses friends or family members pass away, when changes in functional status occur or other personal life big stage things occur. But depression itself is not a normal part of aging. And I feel like I've met a lot of older adults who are depressed and they write it off as I'm just getting older. This is what life is like for me now. And that I want to beg is not true. There's a bidirectional kind of relationship in the way that depression and cognitive impairment can present in older adults. Depression can present as cognitive impairment or worsening of pre-existing cognitive impairment and vice versa. So if you're seeing low mood, somatic symptoms, and fatigue, I want alarm bells to ring. And then we mentioned that the prevalence of depression goes up in patients who are dealing with a lot of medical illness chronically or residing in nursing facilities. But again, this is not a normal part of aging. So how do we pick this up? The PHQ-9, I think, is familiar to all of us. There's also another way to screen older adults for depression that is validated, and that's the Geriatric Depression Scale. I really like the Geriatric Depression Scale. I feel like even for me in my 30s, it's kind of more concrete and easy to understand. You don't have to kind of think about the last 2 weeks in a very abstract manner. I feel like some of the time, most of the time, can get kind of tricky for people to wrap their heads around. And if they're already dealing with cognitive impairment or, like for whatever reason, unable to engage to that degree, the Geriatric Depression Scale is very concrete, yes or no questions. And you'll see that the positive or concerning for depression answer is not consistently always yes or no. It kind of bounces back and forth. And so you get a point for every time you answer one of the underlined answers. A score greater than 5 is quite sensitive for depression, and scores above 10, you have depression. I do want to highlight that sometimes these questions are not culturally in line with how families and patients talk to their providers. I've had at least one Persian family, for example, tell me he's not happy, he's very frustrated, but oh my God, he would never tell a doctor he feels helpless. Like that's not a thing that people would say out loud, especially in that generation. So I think take this for what it is, but also get some collateral from family members about what their baseline is like and what kinds of answers they may give you. Even the geriatric depression scale is too difficult for a patient with cognitive impairment. There's a test called the Cornell Scale for Depression and Dementia. And this is when the clinician talks to an informant, so a family member, a caregiver, or somebody who works at the facility in which your patient is residing. And then there's a few brief questions for the patient themselves. And this is to elicit more objective signs of changes in mood. So they're looking at physical signs, behavioral changes. Is your patient changing day-night sleeping patterns? And are they having ideational disturbances? Here's a chart that I am, for the sake of time, not going to go over in detail, but when these slides are sent out, I think this is helpful information on how we pick antidepressants for older adults. The punchline is that we usually reach for sertraline first, and that's because it has the fewest adverse effects and is generally the most tolerated in this population. The caveat being that we do see SIADH having a greater prevalence in this population associated with SSRIs, and they have been linked to fragility fractures, so just make sure you keep that on your radar. This is another table for perusal in which you can look at comparing and contrasting the different dementia screening tools that we use today. The short of it is that the mini cog is the least sensitive because it's the shortest, but if you're on a time crunch and you're screening somebody in which you have a relatively low pre-test probability, it is a pretty good test to use. This is the one that we recommend that we do at least annually with all of our patients. If they're unable to do a item recall or a clock or both, that is quite highly specific that you need to do some further digging. I hope everyone in this room has seen a mocha before. The real mocha is on the right with the lion, rhino, and camel. And I bring up the impossible mocha on the left. I love this. Somebody published this on Twitter many, many years ago, and I love it because it's funnier the longer you look at it, and B, I think it highlights how cultural the mocha is. And I mean, I think that's a lemur. I don't know what the next two animals are. And so you also see how heavily based in language it is. And so if language is something that's been affected by a stroke or English is not your primary language, then it's kind of like getting the one on the left as opposed to the one on the right that most of us could probably do. I will say that the mocha is published in many, many languages and has been shown to have reasonable sensitivity, even in patients with less education, I give this a shot. And if they're having I mean, this takes some nuance, but like if I feel like they're having a hard time and it's not really reflecting their ability, then we'll talk about alternate tests. Often we do multiple, and I try to glean from all the different things. Next, I want to highlight that I've seen a lot of charts in which people report the score of the MoCA and with little else, and that's not entirely helpful. What I hope that you'll start doing is being more descriptive in your reporting of when you do the MoCA, because that gives you a lot of different information about what is causing the cognitive impairment. So, for example, somebody who scores an 18 out of 30 could have, we'll talk about the different types of dementia in a second, but a really good example is if they're able to name all 5 words at the end, but it took them a long time. That's more suggestive of a vascular etiology because their white matter is disturbed. It's taking the wires longer to reach their destination. Similarly, if they're unable to do it at all, you don't get any points in the MoCA if it takes queuing or multiple choice for them to get it. But if you're saying, was the color blue, green, or red, and they have no idea, that seems like an Alzheimer's-y picture because the information fell out. It was never integrated, it wasn't there. But with queuing, if they're able to remember, oh, red sounds familiar, again, now I know you're very interested in cognitive impairment, darling, but you have to get down. That suggests, again, a vascular etiology. They were ultimately able to get there, but it took a little bit more help. Now that you've done the screening and you are concerned for a cognitive impairment, I have seen some charts that say their MoCA is 15 out of 30, therefore they have dementia. And I just want to pull back for a second and remind you that somebody could score very poorly on one of those tests, but it's not consistent with dementia unless their impairments are across multiple domains, aka those categories that are listed on those screening tests. And somebody could just be a little kooky and or have a learning disability from childhood and so this needs to represent a decline from where they were previously and not that they would have scored a 20 out of 30 even in their 20s. And then if those two things are present, you also need to make sure that those things are impairing their ability to go about their day-to-day life in order for it to be dementia. So you need all three. In the few minutes I have left, I just want to run through a differential diagnosis. I want to highlight that learning to differentiate these things is like a 1 to 2 year fellowship in itself. So I'm going to try to give you a crash course on what kinds of things to think about. And then if your alarm bells are ringing that somebody likely has a neurodegenerative syndrome going on, to please refer them to a specialist like me or a neurologist, etc., so that we can, as a team, start thinking about treatment modalities and support for the patient and their family. Okay, so I'm sure you have all seen HIV-associated neurocognitive disorder in your clinic, and particularly those of you who have been practicing since the 80s and 90s have definitely seen the severe form of this called HIV-associated dementia, or HAD. Risk factors for developing either of those two syndromes is duration of HIV infection. So again, the patients who've been living with HIV for decades are unfortunately at risk for milder forms of this disorder, even if their CD4 count and HIV have been excellent for decades. The thought behind that is that the virus lives in a CNS reservoir that we're not addressing, even if they are excellently virally suppressed. HAN differs from the other forms of dementia on this list because it's kind of global slowing. You'll notice that their gait seems slower, their processing seems slower. They may be getting frustrated because things that used to come very easily to them are now taking more time. And I don't know if this is related or if it happens independently, but you also typically see some affective changes such as depression and irritability with HAND. Next is Alzheimer's disease, by and far the most common of the things on this list. We know that there are some polymorphisms that increase your likelihood for Alzheimer's disease, but the primary risk factor is advancing age, and therefore, unfortunately, we're all at risk for this as we get older. Alzheimer's disease is different than the others because this is primarily a amnestic disorder. And a really wonderful metaphor for this that I heard from a neuropsychologist recently is that the information is going in and then just falling out. It's not retaining, which will differ from one that I'll get to in a second. You'll also see as the disease progresses that they go from being kind of forgetful by itself to having visual construction and language deficits, and that'll really appear quite clearly on the MoCA, which was initially designed to pick up Alzheimer's disease rather than the others. And so again, when you're doing like language recall or verbal fluency on the MoCA. Describing what you see with the patient in front of you is really, really important rather than the score by itself. Classically, when you get an MRI, you see the hippocampi atrophied on the medial temporal lobes, and that makes sense because that's where you learn stuff. Vascular dementia obviously has vascular risk factors at play. And unlike Alzheimer's dementia, these things are getting stored in that little room. They're not falling out. But the metaphor is you're entering a library and all the lights are off and all the books are all over the place. And so the information is there. It'll take you much longer to find them. And so again, the descriptions on the MoCA are really important. If you get an MRI on these patients, you'll see evidence of cerebrovascular disease. This is tricky because, as I'm sure you've seen, MRIs in older adults inevitably show some degree of cerebrovascular disease. And so there are some specific criteria that have been published that are very complicated. But I would say that if you're seeing classic signs and symptoms and history and on the screening tests, and they have a suggestible history, particularly history of a stroke or TIA, that this would be at the top of the differential. Lewy body dementia, I'm learning this past year, is way more common than I learned in medical school and in residency. There is some linkage to Parkinson's disease and family history, which makes sense because they're on the same disease spectrum. There's some new evidence that suggests a history of depression in younger adult life increases your risk of Lewy body dementia. And this is a very difficult diagnosis to make early because it is very nonspecific. You'll see adults with fluctuating alertness that kind of zone out, but we all kind of do that. And then not until they develop Parkinsonian features that you really make the connection, oh, this is a syndrome. I have several patients in clinic in which they were being a little bit more forgetful, a little bit more spacey. There's lots of explanations we made at the time, and not until they developed at least a year later, rigidity or tremors that the diagnosis becomes more obvious. When you do the dementia screening test, you'll see attention. So, serial sevens and clapping your hands when you hear a certain letter, that is often impaired. I don't feel like that test is particularly sensitive though, but you may pick that up. And then there's really not an MRI finding for Lewy body dementia that clues you in. If you happen to trip and fall into a dopamine transporter scan, then you would see a similar pattern to Parkinson's disease, but again, that almost never happens. Finally, frontotemporal dementia has some degree of family history, and these are patients in which they have labels attached to them. You'll hear people being called inappropriate, or in nursing homes, you hear nurses whispering about so-and-so being a pervert. And I want that alarm bell to ring in your head because it's very, very possible that this person is not trying to be outrageous, that their frontal lobe, their executive function is heavily impacted by this disease. And so if you see an MRI, you'll see focal atrophy rather than all over the place, but particularly in their decision-making headquarters, the frontal and temporal cortices, with relative sparing of the other places. I hope none of you are panicking about this, so I want to reassure you that some decrease in processing speed occurs in all of us as we get older. I like to tell patients when they're panicked about being a little bit more forgetful, that they forgot their keys or they made a silly decision, that kids pick up languages like that and the rest of us don't. And so our brains become naturally less plastic as we get older, and that's normal. If you saw me last time struggling to work my new phone, so that's fine, that's normal. If you need more time and energy to encode new information, that is okay and that is normal. It's when it starts to impact your judgment as a pattern and your ability to carry out your ADLs and IDLs in which we start to become more concerned. And then there's this gray area that gives geriatricians a lot of grief called mild cognitive impairment. And that's when you have two of the three criteria I mentioned earlier. I'm going to go back to that slide. You may have decrease in cognitive ability in multiple domains. This is different than how you were living before, but you're still kind of compensating. You're doing okay. We just need to keep a closer eye on you. And some patients live in this gray zone of MCI forever, but about 10 to 20% of those cases progress to dementia every year. So keep a close eye on those patients and be a little bit creative about how we're supporting them and checking in on them. Finally, I want to end with the same note that I ended last time's discussion on, and that's older adults with HIV we know have higher rates of social isolation. And so we need to be creative. I love, love, love our social workers and our case managers about making sure that they have people in their lives. We know that social connection is really important for brain health, and it's important for their physical safety. And people in our lives, their lives may notice changes in them before they do or we do. And so For all those reasons, please plug our lovely older adults in with senior centers. I think we're really lucky in King County, and I can't speak to, but I hope this is the case elsewhere too, that we have all these resources at our disposal to plug people in. This is a picture I've stolen from, I forget which one of these senior centers, but it makes me happy every time I look at it, so I use it in a lot of my talks.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.